Yeah. Oh, Mhm. Mhm. Hello, John.
Hey, Rafael, how you doing?
Very good. Yourself?
Not too good. I don't think the Zoom was working too well. Uh, this has never happened before. Uh, but let's see what happens. So how you been? I don't see your camera.
Yeah, no, I just need a few more seconds. I'll be back.
Okay. Well, Sean, thank you.
Hi, John.
Hey, Sean, thank you for coming.
Yes, yes, it's always pleasure to be there.
Oh, that's
How are
good.
you?
Good, good,
All
good.
okay?
Yeah, what have you been doing? Yeah, are you at the hospital now?
Yeah, I'm on the way actually to the hospital. I was in one hospital and just busy, and now I'm going to another hospital. Tell me, how are things?
Good, good. Doing. We have a big snow-based conference. I don't know if you.
Yeah,
We have
I,
everybody. Everybody's going to be there.
yeah. Sam is doing that, I think.
Yeah. Well, Sam and I have
Exactly.
collaborated.
Yeah, yeah,
Yeah,
yeah, yeah. Because
we've
Sam,
collaborated
yeah,
the last couple of years.
yeah. Sam sent a message also. There is a conference going to be. Yeah, good.
Yeah.
He's trying to arrange everything.
Yeah.
Lot of
I
speakers.
don't
He's
know.
all.
He can get these people fast. I'm really
Yeah,
surprised.
yeah, yeah.
I'm really
No, a lot
surprised.
of people have agreed to speak on that. I've seen that. A
I'm sorry.
lot of people have agreed to speak on that. Yeah,
Yeah.
yeah. Lot
Yeah.
of people.
Yeah. It has a good history. We've had a couple of
Yeah.
years, so that
Yeah,
makes it better.
yeah.
Uh,
Mm.
Hey, John.
so anyways, so you've been working hard.
Yeah, working usual, nothing great. Mm.
Well,
Hey,
that's
John.
good. That's good. Yeah, Sam, that's going to be a big webcast. 2 days.
Yes.
2 days.
2 days, yes. Two
Yeah,
days.
I'd really like to get some
Mm.
students there because, I mean, to
Mm.
have two
Mm.
days with such
Yeah.
fine surgeons, I
Mm.
mean, that's a treat for a student.
Treat, yes. Everybody, not only. And
Yeah,
all good people have agreed to speak on that.
yeah, yeah. My social media has, well, you don't follow me on social media, right?
Yes.
Yeah, the Facebook has been down.
Mm-hmm.
And I'm sorry, did I miss something there?
Hey, John. I I can't share my screen nor switch on the camera. Did you have any kind of
You can't. Let's try it now.
no,
Well, you can't screen share.
no?
That's strange. Yeah, Zoom's been acting kind of weird. Okay, you're on a laptop or desktop.
Mm,
You got to click on the share screen first.
yeah, but I cannot even
Click on
share
share.
the camera.
If you click share first,
But there,
I should be able to tell if you're clicking share. You're not clicking share. 'Cause I should be able to tell if you're clicking share first. I should I should be able to tell if you're clicking share. You're not clicking share. I should be able to tell if you're clicking share. You're not clicking share. I should be able to tell if you're clicking share. You're not clicking share.
I mean, that is not an option available here.
That's not an option?
No.
Well, it should be an option. Uh,
No, nothing.
Well, reboot maybe.
Okay, I'll check.
Yeah, just totally turn off your computer and come back. That should do it. Oh, Rafael, I'm sorry, I didn't let you in there. Okay. How's the screen look now? Oh, there you are.
Now, yeah, it should let me share my screen, I assume.
Are you ready? You ready? Let me introduce you first, Rafael. People will come as we go along. Are you at the hospital now?
No, I am at home.
Oh, okay.
So how long is the presentation, John?
Well, it's generally about 45 minutes or so, whatever you feel.
Okay.
It's flexible. And
Got about 45 minutes.
that's fine. That's fine. It's fine. So people will come as we go along. Okay. Sometimes Ben is busy, so we'll see. Okay, you ready? Okay, here we go. 10, 9, 8, 7, 6,
Hold on a
5.
second.
Okay. Yeah, no hurry. Go ahead. Well, you got something to do?
No, I'm just gonna connect the computer. Yeah, but you can go ahead.
Okay, 10, 9, 8, 7, 6, 5, 4, 3, 2, 1. Good morning from Miami Beach. This is Dr. John Bennett broadcasting for Neurosurgical TV. Today we have the honor of having Rafael Martinez Perez, MD, a guy I've been following for a while. I first met him in Clinica San Carlos. I don't know if you remember. You were there, and then you went to Canada and back to, I think, Colorado. You've been to a few places that I've seen you around. At any rate, Rafael is going to give a presentation today, and he'll explain what he's going to do. Okay, Rafael, welcome.
All right. Hello, John. Thank you for the invitation. So I never been in San Carlos, but nor Canada, but that's fine.
Oh, okay, that was not Canada. Okay.
All right. So yeah, I'm gonna share my screen. All right. Can you see my screen now?
Yes, yes.
All right. So I'm Rafael Martinez Perez. I'm currently practicing as a skull-based neurosurgeon at Geisinger in the Northeast Pennsylvania. And I would just like to discuss about the surgical tenets and caveats as an approximation to the cavernous sinus following this 360 degrees perspective. So we're going to try to entangle this a little bit. First of all, there are multiple approaches. There are different level of comfort among neurosurgeons, including the transorbital, the endoscopic approach, several open approaches, right? But what we need to look for is this perspective that allow us to expose the cavernous sinus from all different angles. And what I have to say here is that nothing is new. In my practice, I'm using two approaches as my workhorses. One is the Miplata approach that we described a while ago. This is no any other thing than just a mini pterional extradural pretemporal approach. And we, in addition to that, I use an endoscopic pixel approach, transcavernous, transpterygoid, as it was described by UPMC, and the further work by Juan Carlos Fernandez Miranda. So everything looks more difficult than what it looks, that what it is at the beginning. So it's important that we cluster the pathology. And what I mean by cluster is that it's important for us there are different classification about what are the spaces on the cavernous sinus, but just for the sake of making this more understandable, we're going to divide the cavernous sinus in 4 compartments: superior, lateral, inferior, and medial. And depending on how this pathology extends, we're going to use different approaches. So as we said, the Miplata, it's the anterolateral approach, or more kind of a lateral approach that I use to entangle this pathology in the cavernous sinus. So everyone who read this, our first paper about the Mi Plata, this was published back in 2021. We just used a completely extradural approach using the pretemporal corridor to access the cavernous sinus, and from the middle cranial fossa also accessing the posterior cranial fossa, following the transmecal corridor and also that corridor that extends between the fourth cranial nerve and the mecal scape through that incision in the dura to access the posterior fossa. But definitely the Mi Plata has a component that is the transcavernous approach. So this Mi Plata is a stage approach. It's a modular, which means that it has different components. And the way we build it is that you cannot move to the following stage until you have complete the first one, which means, first of all, we proceed with the peeling in the middle cranial fossa, then we expose the clinoid and remove the clinoid, then we open the cavernous sinus from above, then we open the cavernous sinus from the lateral aspect, and then we create the incision between the mecal scape and the posterior margin of the clivus, which is that quadrangle that you see here in green, and this is the area that we expose the posterior fossa. But more importantly, we're going to focus on the component that we call the Mi Plata extended that allow us to expose the lateral wall of the cavernous sinus and the lateral compartment of the cavernous sinus. So we go through the peeling. We know that the peeling of the middle cranial fossa are not going to stop for much longer here, but we know that there are two areas where the two layers of the dura of the meninges separates or creates a virtual space in which can be incised to start the peeling. One is the meningorbital band right at the front. It's in the most anterior aspect of the most superior aspect of the screen, and then is at the level of the mecal scape or V2, the foramen-ovalic, which is the other lumbar that we might use to peel the middle cranial fossa. In our practice, given the design of the craniotomy, and since this is a pretemporal approach, sometimes we don't need to peel the whole temporal lobe, and we always decided to do from anterior to posterior. Therefore, we use the meningorbital band. So where to find the meningorbital band? It's after drilling the sphinx ridge, we find this little spot, which is the entrance to the superior orbital fissure. And it's a half by half cottonoid, the same length of a half by half cottonoid, the distance of the meningorbital band that can be sectioned. And then by pulling the temporal lobe backward, always in my practice using sharp dissection, we're able to expose the lateral wall of the cavernous sinus, the mecal scape, and as you see in the left side of the picture here, the tip of the clinoid process. So it's particularly this clinoid process, this triangular shape or cone structure that marks the roof of the superior orbital fissure. It's displayed right over the superior orbital fissure, and you see the relation between the meningoorbital band attachment and the rest of the superior orbital fissure, that as we cut, we're able to pull the temporal lobe backward. So as we know, this is the sphinx ridge, the supraorbital fissure below the clinoid process, and the clinoid process also form the roof of the optic canal. And the clinoid process is formed by a lateral pillar, medial pillar, and inferomedial pillar. And the the medial and inferomedial pillar conforms the walls of the optic canal. So after we remove the clinoid, we're able to unlock the roof of the cavernous sinus, and then we focus in this area, which is the oculomotor triangle. And that is the area where the oculomotor third cranial nerve cross from the subdural space into the cavernous sinus. And it's very relevant because this is the area that we need to open. You see here with a feather blade, we just pull from the anterior component of the petroclinidal ligament, and it's divided following the third cranial nerve. And by using a feather blade, this is a maneuver that I can tell you that is safe. We're going to encounter some bleeding from the superior compartment of the cavernous sinus, and we can extend this cut all the way towards the internal dural ring. You see here in this picture, this would be the first maneuver of the exposure of the superior compartment. But then and this is the final view, right? We see that the third entering the cavernous sinus and how this is decompressed. And this might be enough in many cases, but in other cases, in which are intrinsic tumor of the cavernous sinus, the tumor growth between the carotid and the oculomotor nerves and the Meckel's. So in that case, we need to access the lateral compartment of the cavernous sinus. So how do we do that? Usually the most common approach is between the fourth cranial nerve and V1. This is called the Parkinson's triangle because this was described in the 1984 by Parkinson as a route to access the aneurysm from the internal carotid artery, from the lateral wall, or even the meningopephyseal trunk in CC fistulas. So this is like I said, this is the access to the lateral compartment. We can access through other windows such as B1 and B2, but there is more bone drilling work that we need to do. We also can access between 4 and 3, but probably this is the widest and the safest. So this is the final picture that we would have by, opening the Parkinson's triangle, or the so-called the infratrochlear triangle. We're able to mobilize V1, and by mobilizing V1, we can see here in the upper right how the sixth cranial nerve enters through the Dorellos canal. It's important to mention that the sixth cranial nerve is at the same level as V1, so the only way to visualize the sixth cranial nerve from a transcranial approach in the cavernous sinus is by either cutting or by significantly mobilizing V1. As you see in the pictures from below, we have access to the superior compartment, which we expose by opening the oculomotor triangle, right? And then we have the lateral compartment, and if we even mobilize a little bit better the V1, we expose 6, but also we are able to expose a little bit of the medial compartment of the cavernous sinus, but this is not much. And these are the different areas and corridor through which we can access the cavernous sinus. So as a concept, we all know that the resection of the meningiomas, we follow the 4 Ds, which is the vascularization, detachment, debulking, and dissection. And this is very important because in cavernous sinus meningiomas, we found that these are the arteries that are most commonly feeding the tumor. Started by the medial meningeal artery, the recurrent orbitomeningeal, the meningopephyseal trunk, and then some branches coming from the medial fossa, such as the foramen ovale artery. All these branches have been taken care through the mini pretemporal approach. So this is an art illustrating how these arteries are disposed, the 3 most important. So with the peeling of the medial coronal fossa right at the convexity, we find and coagulate and sever the medial meningeal artery, so we are able to devascularize the tumor. Then as we move into the tip and the tip of the temporal lobe is retracted, we find the recurrent orbitomeningeal artery, which is a branch that usually comes off the ophthalmic artery, goes through the superior orbital fissure or through the optic canal. So we take care of that once we remove the clinoid or during the peeling. And then as we move the temporal lobe backward, we are going to start finding the meningopephyseal trunk getting out and getting into the posterior aspect of a completely cavernous sinus meningioma, for example. I just want to show you here a video presentation. So we said that we're going to differentiate between what we call extrinsic tumors of the cavernous sinus, which are those that originate somewhere outside of the cavernous sinus and secondarily invades the cavernous sinus, for example, a sphenoorbital meningioma, or even petroclival meningiomas that later on just tend to invade the cavernous sinus. And we're going to differentiate from those that are called intrinsic cavernous sinus. You will see why. Intrinsic are those that originate in the cavernous sinus, and they have a different behavior. Our goal here is not complete resection, especially in most common tumors that are in the vast majority benign, but in preserve the function of the patient. So for this extrinsic tumor, this is a very common behavior that they tend to invade the superior compartment of the cavernous sinus that we see here in the right. Therefore, our goal is to decompress the superior compartment and decompress the third cranial nerve as it enters on the oculomotor triangle. because usually these layers of dura get thickened when they are infiltrated by tumors such as meningioma or other tumors around the medial cranial fossa. So this is probably the most important aspect of the extrinsic tumor. Here I would like to present a case. This is a lady of around her 40s who presented with a partial third coronary palsy, vision loss, and retroorbital pain. And you see here this tumor extending from the orbit all the way into the cavernous sinus, not big, but the role here was to decompress and preserve function. So as you see, we perform a mini-pterional craniotomy. We find this structure entering the superior orbital fissure, which is the meningorbital band. We proceed with sharp dissection, right? And always sharp dissection and not blunt dissection, because here is where the tumor gets progressively devascularized as the tumor expands between the both layers of the dura. This is actually a positive finding as we start feeling more encouraged that we were going to be able to respect the lateral wall of the cavernous sinus and resect the tumor in its entirety. So here we expose the lateral wall of the cavernous sinus on Meckel's-Cape, and we proceed with drilling. With this tumor, we proceed with a 3-layer decompression, which means the first layer is the bony decompression. At the bony decompression here, we're opening the superior orbital fissure. And now we're going to proceed with opening of the optic canal. The superior orbital fissure needs to be open in this tumor because many patients complain of retroorbital pain, and it's usually due to the compression by the neurostructure at the level of the superior orbital fissure. Now we have removed the enteroclonic process, and as we proceed with the peeling, we see how progressively vascularized the tumor. And this is the maxillary strut that stays between the orbit and the medial cranial fossa. So we're going to drill and decompress in order to communicate the tumor components from the orbit with the medial cranial fossa. By doing that, we communicate both cavities. And as you see, I'm respecting the periorbita, which is a continuation of the cavernous sinus, and I keep peeling the tumor backward without any further bleeding and without even entering the subdural space. Now is the second part, which is the dural decompression from an extradural approach. So we plan our dural incision first in the temporal dura, and as we move towards the extradural cavity that we create in the peeling, we progress with this cut in the direction of the Meckel's-Cape. So we communicate both cuts, and we are decompressing the Meckel's-Cape at this point as the patient had facial pain as well. And this cut is aimed in the direction of the oculomotor triangle that you saw in the previous graph. Now we go with the other cut frontally, and we continue this cut towards the falciform ligament and then through the external dural ring. Falciform ligament needs to be cut, otherwise the optic gets compressed by the tumor and strangulated against the falciform ligament. So we cut, and then we cut the external dural ring for 2 purposes. One is to devascularize the tumors even further, and then to be able to roll the tumor without pulling the carotid after me. So we complete this stage, and now we're proceeding to opening the basal cistern to give a little bit of the space and go in the direction to find the third coronary artery, which is probably the main issue of the surgery. The patient presented with a third coronary palsy. Now we proceed with further tumor debulking in the medial cranial fossa, and you see how now the medial extradural cranial fossa and the intradural fossa are communicated. There you see the posterior clinoid, tentorium, and between both you see the third coronary nerve. And here it's where the key of this portion of the surgery, where we just go into the anterior petroclinoidal ligament that we have there in the picture. We know that that is a dural structure that can actually compress the third coronary nerve. I have resected the tumor, but the surgery doesn't stop here. We need to decompress this third. So as you know, the colomotor triangle is composed by this thickening of the tentorium caesura, which is the anterior fold of the petroclinoidal ligament, the interclinoidal ligament, and the posterior petroclinoidal ligament. So we are cutting the anterior petroclinoidal ligament here, similar to what we do in the carpal tunnel, for example, for a median nerve decompression. And you see how the nerve now it's decompressed. We just mildly open the superior compartment of the cavernous sinus. And this is often enough to achieve gross total resection, but more importantly is the improvement of the patient. And you see how at 2 weeks post-op, the patient was significantly improving from his previous palsy. Similar with other kind of tumor, this is a very a small petroclinoidal ligament. It's a tumor that probably extends more through the tentorial incisura and secondarily invades the posterior compartment of the cavernous sinus. And see how here we leave the component of the tumor that is purely intradural, but our goal was to resect everything that was outside of the cavernous sinus and to decompress that oculomotor triangle. This patient also did well in terms of recovering the parts of third coronary palsy that she had. So, but this is different to, for example, intrinsic tumors of the cavernous sinus. Intrinsic tumors of the cavernous sinus, for example, cavernous sinus hemangiomas, they grow from the lateral wall of the cavernous sinus. So they tend to grow medial to the nerves and lateral to the carotid. So just by simply decompression the superior compartment, it's not going to be enough. So besides that, we need to access the lateral compartment of the cavernous sinus and unfortunately work between the nerves and decompress those nerves because they are often going to be compressed by a tumor that expands such a lateral compartment. So here I would like to present this case. This is an old gentleman, 65 years old, presenting with this T2 hyperintense mass, expanding the cavernous sinus. This is very typical for cavernous sinus hemangiomas. And you see how there is not much of hyperestosis. We're drilling the lateral wall of the orbit. We open the superior orbital fissure wider. As you know, many of these tumors have retroorbital pain. And now here we expose in the tumor that we see that it's slightly different than the meningiomas. The meningiomas, they also tend to bleed more. Partial resection cannot be done as many of those tumors tend to bleed as we remove it. But here we find the forecoronary nerve by monitoring. And we see that the forecoronary nerve, it's lateral to the tumor. So the tumor is medial to that forecoronary nerve. We tilt the microscope, and there we are going to remove the enteroclonic process in the search or the unlocket of the cavernous sinus. So we're looking now for the third coronary nerve. So we are drilling the optic canal, and in this view, we cannot see the third coronary nerve. So we assume that the third has been displaced up medially. We need to open the Sylvan fissure in this case to give more angle, some brain relaxation, and be able to access the subfrontal corridor. As we peel and we continue peeling, we see this weird relation between the carotid and the optic nerve. The optic carotid is pushed up by the tumor, so it's kind of confusing at the anatomy. We continue to move forward with the dissection. Venous drainage, it also involves the tumor, and those veins needs to be sacrificed. And as we predicted, here's the third coronary nerve who's up and middle. And we see all the perforators from the posterior communicating and anterior choroidal. As we deflate the tumor, we're able to find the third coronary nerve in all its extent from the interpeduncular fossa all the way into the cavernous sinus. We continue through the coagulation of the tumor capsule. And we're going to proceed with removing the tumor and open the lateral wall of the cavernous sinus. So we incise the infratrochlear triangle. Everything is invaded by the tumor. We patiently try to decompress the fourth coronary nerve carefully. Here we have the tentorial edge that I'm going to preserve until the end, just for reference. I'm drilling lateral to the, I'm using the sonopet lateral to the carotid. I know that's probably the area where I need to stop. I'm doing sonopet in the posterior compartment. And here I start finding what end up being the sixth coronary nerve. I follow the sixth coronary nerve anteriorly. That was very displaced outward, but I know that medial to that, I cannot proceed with further sonopet because I'm going to find the carotid. So my only role after I decompress the sixth is just decompress the mecal scape as I'm doing here. Opening the mecal scape and removing the tumor that is invading the mecal scape, and the tumor comes off nicely from the middle cranial fossa, as it is seen here. Now, finally, find the tentorial edge or the anterior petroclinoidal ligament, where we're going to use to finally decompress the third and remove a little bit of tumor in this area. And this is pretty much satisfactory. Now I'm just going to remove the portion of the tentorium between V1 and and forecoronary nerve, and this should be enough to just have a full decompression. It's not the goal of the surgery, but by removing this dura, we are completing the mipleta approach, and you see the exposure of the interpeduncular fossa, vascular, the origin of FCA, and the third coronary nerve, how is it seen in the picture. We achieve a good but non-gross total resection, but more importantly, although the patient has some deficit, post-op, he recovered his third completely at 6 months follow-up, same as his vision. So we also might need to use this approach for other tumors that are, although not completely intrinsic from the cavernous sinus, they behave as such. So this is a patient with a pituitary adenoma resected years ago, and the tumor, it's rapidly infiltrating the inferior compartment of the cavernous sinus and growing all the way into the middle cranial fossa. So for this patient, I also needed to do the same mipleta approach to have some decompression of the third coronary nerve. The second workhorse of my approach, I just own my practice to the work from UPMC, from Juan Carlos Fernandez Miranda, in which the important feature is how he described how this ligaments are attached from the pituitary gland to the medial wall of the cavernous sinus and the clinoid. So there are many ligaments: inferior paracellular, superior paracellular, interclinoidal, and carotid-clinoid ligament. But more importantly, I would say that the most two important for the dissection of the middle wall of the cavernous sinus and mobilize the carotid medially to access the lateral compartment is the inferior paracellular ligament that extends from the pituitary gland to the anterior aspect of the ICA. And this needs to be coagulated and severed, but always coagulated first. But it's because, as you see here, often the inferior epiphyseal artery just goes right immediately above this ligament. And if we avulse that artery, we might have an internal carotid injury, and usually it's bleeding. It could start bleeding from the inferior epiphyseal artery, but as we try to coagulate, we create a hole in the carotid, and it can turn into a big adventure, right? An injury of the carotid artery. And then the second most important for the cavernous sinus itself is the carotid clinoid ligament. This ligament extends from the pituitary gland and the middle clinoid process into the anterior clinoid process. So we're going to find this ligament after we remove the middle clinoid process. And sometimes this ligament can be calcified, so it cannot be cut entirely other than drilling. But sectioning this ligament or drilling, if it's calcified, it's extremely needed to access this superior compartment of the cavernous sinus and also move the carotid medially to access the lateral compartment. And we'll see why. So this is a stepwise dissection. I'm not going to step for much longer here. You guys have the dissection in a recent paper that we just published. It came out on Acta Neurosurgical last month, but it is also the same approach as described by GFN. So first we expose we enter the sphenoid sinus. We expose also the transpterigo space. Oftentimes we remove the whole bone from the anterior wall of the cavernous sinus and also from the pituitary gland, and we do 2 incisions in each side. We know that the medial wall of the cavernous sinus is going to be right here. So we do 1 incision at the level of the pituitary gland, another one right above the internal carotid artery. We control with flow seal, and then we proceed with cuts as described here. So 1, 2, 3, and 4. The 1 correspond to the inferior paracellular ligament, and this is the cut that I always said that it needs to be coagulated and then severed. 2 is also part of the inferior paracellular ligament, and 3 and 4 correspond to the carotid-clinoid ligament, and you see the relation with the medial clinoidal process. After we do that, as you know, by removing this ligament, the carotid-clinoid ligament, we're able to access the superior compartment of the cavernous sinus here, and the third coronary nerve that runs through the superior compartment as we saw in the open dissection. Then, because we detach that ligament, we're also able to move the carotid medially and expose the lateral compartment of the cavernous sinus between carotid and then third, fourth, and V1, and we see how this sixth corner approximately runs at the same level as V1. So this is also a modular approach. That's why I choose it in particular. So we have a component that start by removing the medial wall. There are some times that we also need to cut the carotid-cochlear ligament, such as the two figures in the left, in which we want to expose the medial compartment and the superior compartment. And then sometimes we need to expose very well the inferior compartment and the metallscape. And in order to get access to the pink area here, we need to drill in a more or lesser degree the pterygoid base to access this area, to have a fully exposed of the inferior cavernous sinus. And then if we cut the carotid-cochlear ligament, we can mobilize the carotid medially and expose this lateral compartment. I'm going to show how. Likewise, we have different ways to access different compartments of the cavernous sinus, but let's start by doing this classification. So we have NOS2 pituitary adenoma, right? Especially those that we have invasion of the medial wall of the cavernous sinus, and we need to assume that full resection needs to be achieved, such as in acromegaly or in Cushing disease. These are patients with either acromegaly or Cushing, so therefore it's extremely important, the spine being grade 2, to have complete resection of the medial wall. So we're going to see how we do this. This is a resection of the middle wall of the cavernous sinus. This is a patient with Cushing. We see how the tumor is eroding the base of the sella, but beyond that, we're exposing the anterior wall of the cavernous sinus. So by using a diamond drill, this is a maneuver that is safe. We excel the bone, and we're able to remove the bone all the way up, and we communicate with the sella. Then in this case, we have to ensure that we expose a little bit the petrous apex, or getting close to the petrous apex, to expose the inferior compartment of the cavernous sinus, and we open dura in a cruciate fashion, first in the direction to the pituitary gland, and we proceed with the removal of the tumor in the sella. We use a succession of different Angelina dissector to preserve the plane between the tumor and the normal gland that is behind my suction tip. We'll proceed with the bulking. And now we are going to open the cavernous sinus, the anterior wall of the cavernous sinus, which is the second tangential and parallel cut. So we're opening the anterior wall of the cavernous sinus. Especially careful here, introducing the deeper blade of our dissection. And this is what I said: I coagulate and divide the inferior paracellular ligament prior to section it. And here you can see how the carotid comes into view, but we're able to dissect nicely the medial wall from it. Now I'm dividing the superior paracellular ligament and carotid-cochlear ligament as I move backward, and I start insinuating the superior compartment of the cavernous sinus, and I proceed just to make sure I coagulate the inferior epiphyseal artery before I cut, and I proceed backward in the direction of the superior compartment of the cavernous sinus. So there, I'm just putting a cottonoid to protect the carotid, and I'm just gonna divide and section the medial wall from the diaphragm sellae, in able to resect it in one piece. You'll see that it's a very thickening of the middle wall of the cavernous sinus as it's infiltrated by tumor. And we're going to send this and separate the specimen to just allow our pathologists to determine what is the degree of infiltration. Finally, we see the gland. It's hidden by dura, but it's pulsating in the right. The diaphragm, it's a very low CSF leak. So we felt that there was going to be enough to be reconstructed with Duragen. We see the carotid, superior compartment that is insinuating here, and now we are going to take a look laterally and see how we expose the lateral compartment. And we objectivize that there was no tumor left. reconstruct with the cellulose or with a Duragen graft, and no further nasoseptal flap was needed in this case. The patient did well without any CSF leak and with cure of the Cushing disease with a cortisol level of less than 0.02. So now this is let me show you here. So what's going on here? I just would like to show you this this video here, just because it represents very well how we dissect the middle wall of the cavernous sinus. So sometimes we might need for invasive cavernous sinus meningioma, such in this case, this is a patient with who has been radiated when he was a kid, and he developed this diaphragm and middle wall cavernous sinus meningioma. So we are doing the same, right? We're just exposing the anterior wall of the sella all the way to the tuberculum, and also opening here a little bit the optic canal, in particular because this was also a tuberculum sella meningioma. Here we are removing the midoclinic process, as you see there, and that's where we know we're going to find the carotidoclinic ligament. So those are both midoclinic process, and we are doing the incision at this junction between the anterior wall of the cavernous sinus and the ligament of the sella. We open a little bit the cavernous sinus. We control hemostasis with injection of flow seal. And then once we achieve the hemostasis of cavernous sinus, we are able to remove the dura corresponding to anterior wall of the cavernous sinus and the dura around the pituitary gland. So here I'm just trying to find a plane between the tumor and the pituitary gland. Pituitary gland was very attached to the tumor because of prior radiation. The tumor was very infiltrative. And now here I'm dividing the carotidoclinic ligament and also sectioning the diaphragm. That's why we're having this CSF. It was expected because this is a tumor that was felt to be also tuberculum sella. It was more kind of a tumor expanding from the diaphragm, so that was a slightly different, and that's why we needed to cut the diaphragm area early on in the case. Here I'm dividing probably carotidoclinic ligament, and I'm going to remove this first component of the tumor, the one expanding. Here I couldn't preserve the gland, but I'm able to preserve the pituitary stalk that I'm lateralizing here. Hopefully I can preserve this in order to have a good function. The patient, remind you, the patient was completely panhypo before surgery, but it was important to preserve the stalk so he doesn't develop DI in addition. Here I'm removing the tumor, and that's where I start seeing the posterior clinoid. So I need to cut the carotidoclinic ligament. I just remove the final components that are invading the sella. Like you saw in the previous picture, I coagulated the carotidoclinic ligament. This is the supracellular space, both tubercular, those mammillary bodies, and the pituitary stalk medially, and this is the tumor remnant and the carotid artery. So we are just trying to expose this area here. So we coagulate the branches coming from the carotid. This is a meningioma, so it's gonna even have a normal branches feeding the tumor that we need to be patiently coagulated and divided. As you see, once we section this artery, is relatively safe to remove this tumor from inside the cavernous sinus. The patient is radiated, so we think that there is a high chance of this tumor being a grade 2, and therefore we aim for gross total resection. So in this case, it's more kind of also diaphragm with clear invasion of the subdural space. So we did a nasoseptal flap, and we see how we achieve complete resection. And this is a little bit, now when we are trying to expose tumor that invades the inferior compartment of the cavernous sinus besides the medial wall, We mentioned that we need to drill a little bit the base of the pterygoid, or at least have a good exposure of the lateral recess of the cavernous sinus. And that's why I want to show this case. This is a patient with a chondrosarcoma. Chondrosarcoma are usually originated in the petroclival fissure, and they can invade other structures, such as the cavernous sinus. This is a little bit abnormal because it has a huge component going suprasellar and even to the anterior coronal fossa. The patient came blind to my clinic, but this was proven to be a chondrosarcoma, so we were aiming to have complete resection to achieve tumor control. So here we see the green, which is the middle compartment, and the pink, which is the inferior compartment. And as you see in the pictures from above, the B illustration, we need to expose that posterior knee of the carotid where it comes the inferior apophyseal artery very clearly, and sometimes do a little bit of a petrosectomy to be able to see the whole tumor expanding from the petroclinoidal fissure. So I just want to show you here this video presentation. It's going to try to be a little bit. So we are exposing, again, we're exposing the sella, tuberculum and planum, since we have tumor extending into the anterior coronal fossa, right? We're removing the tumor from the anterior wall of the cavernous sinus. Here we have the planum. And as we move laterally, we are trying to decompress the optic canal with the hope that the patient might have any kind of improvement, although that was very unlikely at this stage. So we open the dura. This is more kind of this consistency of chondrosarcomas, right? That it's a cartilaginous, almost soft tissue with areas of more calcification. But here we're just trying to debulk the tumor originally. This is not very relevant for the sake of this case. I just would like to show you a little bit anterior. So here it is. Here I'm drilling a little bit of the petrous apex in order to expose the inferior aspect of the carotid artery. There's always that pterygoid plexus that we need to coagulate, right? Here I'm exposing also a little bit inferior carotid in the other side. We proceed further with the bulking. There is tumor that we're going to try to separate there from the cavernous sinus, but we early see that the tumor is embedded in the cavernous sinus in the back. The posterior edge, the posterior knee of the carotid is right there, and we need to be very careful with the dissection. So we're going to proceed with removing the tumor that is in the anterior coronal fossa. So we use our dissection to cut the diaphragm in one side of another. Where here the challenge is to find the pituitary stalk, right? But this is not for the sake of this intervention. I'm just going to try to move a little bit faster. Here we start seeing the pituitary stalk in the right side of the patient. We'll proceed with sharp dissection to avoid much of a pulling from the stalk. We didn't have a feather blade for this case. We're using different kind of dissection and sharp dissection with scissors to preserve the stalk. And we see that the stalk is just very flat over there. I'll see that the stalk is displaced to the right of the patient, still preserved. And we see the mammillary bodies, the basilar artery, the superior cerebellar and the posterior cerebellar, posterior cerebral, I'm sorry, and the third coronal nerve between posterior cerebral, the P1. This patient has fetal circulation, so it's more dominant, the PCOM in that side. The base of the third ventricle, right? So then now we need to focus on this area that we know that we left tumor here in the posterior compartment of the cavernous sinus. So we need to expose a little bit more the anterior aspect of the cavernous sinus. And as you see, that's why we needed a little bit of exposure of the pterygoid wedge, because it's very difficult to get to the anterior aspect. So here I'm just going to drill just a little bit the pterygoid wedge to expand a little bit more the lateral recess to be able to work with the instrument around that area. So now we are removing the wall anterior of the cavernous sinus. The carotid was very displaced laterally, so that's why we needed further exposure. And here I was able to reach approximately the projection of the lateral edge of the carotid. We are drilling, irrigating a little bit, and now I'm just trying to remove this carotid from the inferior compartment there, superior compartment, middle compartment, and finally this is the inferior compartment. I'm just using a 30 degrees of scope with a very angulated suction. We see the carotid, the posterior bend of the carotid down there. And we have been able to remove the posterior compartment of the cavernous sinus in that area. So this is all for this case. We achieved cross-thoracic resection, we preserved the stalk, but unfortunately the patient did not recover any vision as suspected. So this is, for example, also the approach that we need to do in NOS4 pituitary adenomas when we aim to have a complete resection. This is something that is particularly needed in acromegaly and a patient with Cushing. Is more controversial to do for non-functioning pituitary adenomas, but of course we always aim for the best. And as long as it is safe for the patient, as you will see, we're trying to proceed with a complete resection. So in the pituitary adenoma, the NOS4, we need to mobilize the carotid. So as we remember, we need to cut the carotid-coccygeal ligament and move the carotid with a dissector as we see in the inferior compartment here. So we're going from medial to lateral. And as you see here with the endoscopic initial approach, we can also get to different areas, right? So here, this is another chondrosarcoma, but it's a multi-compartmental. I just would like to show you how the carotid is mobilized in this case. For a little bit of discussion, we see that the tumor expands even into the middle canal fossa. So here we use what we call the lacerum gate, because accessing the foramen lacerum, it's the area where it's going to give us exposure to all the other structures. So it's key. I'm not going to get into much detail into this. This is probably for all the discussion. But from this foramen lacerum, we need to mobilize the Eustachian tube. We need to mobilize this phenopalatin ganglion. And we need to do a transthetic approach to get to the most inferior aspect of the carotid. I'm not going to get into much detail here. This is the sinonasal space. Here we are exposing the jugular foramen. I'm just going to leave a little bit for a little bit of understanding of the surgery. So we're exposing the jugular foramen. The Eustachian tube is going to be mobilized here a little bit inferior. We are drilling the palatine bone, and we are following the palatine nerves to expose the component of the pterygomaxillary fossa so they can be mobilized and start drilling around the pterygoid. So here we are moving the pterygoid from 6 to 12. This is a way we're never going to find the carotid artery, because the carotid artery is always found lateral and superior to the median nerve. And as we do that, we proceed with an infrapetrosal approach to communicate with the previous jugular foramen and expose the petroclival fissure at that level. And here we see how we are approximated to the anterior edge of the carotid. So we need to keep drilling forward into the direction of the internal carotid artery. We move a little bit up, and now here I'm exposing the paracellular and paraclival carotid. We're going to keep moving. We follow this two landmarks, which is the Vivian nerve and the petrosphenoidal fissure, and drilling between both. And by doing that, I'm able to access the origin of the paraclival in the transection from the Petrus carotid. Here it is. This is a more complex approach for the transcavernous, but this is for you guys to see how much work we need to do in order to expose the cavernous sinus in this case. Here I'm using a traction point to the sphenopalatine ganglion, mobilizing laterally, and here I have a good exposure of the paraclival and paracellular carotid. I want to drill a little bit of the midclivus, and now I'm using a right contralateral transmaxillary approach to drill behind the carotid and the petrous apex, and I continue my dissection in the direction of the foramen lacerum. And here it is where the tumor invades the foramen lacerum that needs to be divided from the carotid. I also want to remark that this is relatively safe as we follow the landmarks. We're removing part of the petrous apex, but here what I'm trying to find is the sixth coronal nerve. So in order for that reference, we need to find the petrous process of the sphenoid bone, which is the continuation of the petrous apex, but more located into the sphenoid bone. It's part of the sphenoid bone. And here I'm removing the midoclinic process. So all this bone work is needed to find the sixth coronal nerve. Here's the petrous process of the sphenoid bone, and this is a good and safe landmark to find the sixth that's described by JFN, because we're going to find this sooner than the nerve, as opposed to when we are just trying to find the Dorellos canal, because the ligamentous structures are behind the nerve. So by doing this, we feel that the nerve is more decompressed, so it's not strangulated against to the bone, and then we can find it here. We see that the tumor is infiltrating the dura, so it needed sharp dissection. And we are keep going in the direction to free the sixth coronal nerve. We still have some component of the petrous apex, but the sixth nerve is felt to be free. We are going still in the direction of the medial wall of the cavernous sinus, which is where we still know that we have some tumor. We're finalized drilling the petrous apex in its entirety to expose fully the petroclival fissure. And finally, we have here the carotid and the cavernous sinus. So now this is the key part where we open into the wall of the cavernous sinus. This is not a feather blade per se, but we're using this to remove the dura in front of the carotid. See that the hemostasis is achieved by the tumor itself. And now I'm pulling behind the carotid this tumor that is completely extradural behind the carotid and remove it in total from the middle coronal fossa. So now we'll see how we have exposed medial, inferior, and superior compartment, and now there it is, lateral compartment, and even the dura of the middle coronal fossa pulsating there. Now find 6. There's a little bit of tumor invasion into the intradural space. So we needed to have the reconstruction with a nasoseptal flap. And here we have complete resection, and the tumor is still disease-free after 2 years. Sometimes we are going to need a combined approach, and this is by doing a combined approach, we saw that we're able to go the transcranial all the way to the medial compartment and through the endonasal all the way to the lateral compartment. Sometimes we can do a combined approach and we don't need to be crossing those nerves. This is going to depend on the pathology, but especially the consistency of the tumor. So for most of pituitary adenomas that tend to be soft, we usually tend to approach them through an endoscopic endonasal approach. And if we needed to do a little bit more of exposure of the lateral compartment, it's doable. But when we have calcified meningiomas or patient with several involvement of coronal nerve is going to extending severely into the middle coronal fossa, this needs to be combined with an open approach. So for example, this is another functional preservation surgery. This is a lady, she had complete blindness for 2 years. But for her, the most important is he had terrible pain behind the left eye and a horrible exophthalmos. So for this lady, we needed to achieve, first of all, the compression of the superior orbital fissure, opticking out, and put the eyes back into place. We see that we have significant hyperestosis in the posterior ethmoidal cells, but also into the maxillary strut. So both structure needs to be drilled, and one approach is not enough. So for this lady, we did a Mi Plata originally, followed by endoscopic indonesial approach. And this is the results radiographically. This is the immediate post-op, and you see how the eye is already getting into place and achieving a good resection. But of course, we leave calcified tumor in the cavernous sinus because there is no point to put at risk the carotid of the patient. But more importantly, the patient has a very good aesthetic outcome after surgery.
Mira para allá. Mira para allá.
These tumors are
Mira para
terrible,
abajo.
terrible because they tend to recur and they might need more surgeries in the future. So we need to be aware when we consult the patient and be particularly emphatic that this might not be the last surgery, but at the same time, try to be ambitious and try to give a lot of space for decompressing the eyes and provide the longest support and the longest relief that we can. This is another case that I also required to do dual approach. This is a case that I did at the beginning of my practice. Probably if I go back now, I would only do a Mi Plata, but there was a big component here in the midline that was compressing the optic nerve. That was very fibrous and it was bleeding, so I felt that it wasn't safe to start coagulating the tumor at that area and compressing of the optic nerve. So I proceeded in 2 stages with an endoscopic indonesial approach, followed by the Mi Plata, as we see here. And this is a recent publication that I have from my time from my previous fellow with Dr. Youssef, and we found that by combining this approach in a less aggressive manner, which means not accessing the lateral compartment in the endoscopic indonesial and not accessing the lateral wall when we are doing transcranial, we can achieve similar or even better grade of resection and exposure, of course, with 2 approaches, but very likely as we're not crossing the nerves with less or potentially less risk to the patient. Of course, this is on a patient-to-patient basis, and we cannot make assumption in a large data of patient, but this is something that we are going to investigate even further. And this is a little bit of the algorithm that I just defined for my practice. Of course, it's very important to define when it's a pituitary adenoma or a meningioma. If it's a pituitary adenoma, I usually tend to go endoscopic indonesial approach. Sometimes, if it's only NOS 2 and 3, you only need medial wall resection. If you have significant involvement of the middle cranial fossa, more than 1 cc, then I would add a Mi Plata approach. But if not, everything is enough with an external, with an endoscopic indonesial approach with a transcavernous variant. When there are meningiomas and there are tumor deficits, we tend to operate all those patients. If it's midline, such as tuberculum cell and planum, I offer them an endoscopic indonesial approach. If it's extrinsic from the cavernous sinus or even intrinsic tumor, I offer a Mi Plata approach. And of course, when there are malignant tumor, we usually need to be aggressive. We cannot leave any tumor cells, so we usually tend to do more combined approach, both Mi Plata and endoscopic indonesial transcavernous approach. I just want to, after all this year, I want to thank to all my mentors. I've been so lucky throughout my career, and I always hope to take the best and always a little bit of bad of them. But I'm very happy. I'm very fortunate for the experience throughout my life. And nothing else. Thank you everyone for watching, and I hope you enjoy it.
Thank you very much, Rafael. Hashar, are you there? And I apologize for not having a better turnout. We've had some problems with Facebook. They put us on probation, or they suspended us actually, because I was a bad boy. But I'm sorry we didn't have a better crowd for you.
Hi, John.
Yes, go ahead, Harshad.
Hi, John. Hi, Professor. This is Dr. Harshad Parekh. I'm a neurosurgeon from Mumbai, India. Excellent presentation. Very elaborate presentation for the cavernous sinus approach. You have given both transcranial and endonasal. Wonderful technique. And I must congratulate and compliment you for that. Superbly demonstrated. Couple of things I would like to understand from you. If when you are doing an endonasal pituitary, which is extending into the cavernous sinus, you open the cavernous sinus. If the tumor is going beyond the carotid artery, means lateral to the carotid artery, how do you manage that? In the same way, you do a two-stage procedure. This is one thing. And second thing, when you are holding an endoscope, do you have an endoscope holder or your assistant is holding the endoscope?
A very good question. Thank you, Parek. Thank you, Parek. So first of all, for pituitary adenomas extending into the lateral compartment, I try to plan ambitious and try to resect the tumor that extend lateral to the carotid by doing a transcavernous approach. If the tumor it's more than 1 cc into the middle coronal fossa or past the limit of the lateral wall of the cavernous sinus, which is very unlikely. This is not a typical pattern, as you know, from pituitary adenoma. I told the patient that I might need an open approach. For the endoscopic endonasal part, when accessing the lateral compartment, it's key for this tumor that has significant involvement of the cavernous sinus. I start my dissection in the cavernous sinus now. I know that I haven't showed that in the videos, but what I found, and it's my experience, that sometimes, especially when there is no match invasion of the cavernous sinus, I remove the component of the tumor in the sella, and then I move into the cavernous sinus, and the cavernous sinus collapse. So basically, the carotid artery goes after you, and it's very difficult to find a plane, and it's more difficult to find the tumor, and that's when problem can happen. If I'm planning to expose the lateral compartment in particular, as I said, it's very important to drill the inferior compartment of the cavernous sinus. And to get there, you probably need a little bit of transpterygoid approach. Or if you're lucky and you have a very good lateral recess, and it's in an area that you can work well because you are working through the left nostril and the microscope is going through the right nostril and the pathology is in the right side, you can get away without needing to drill the transpterygoid. But I usually tend to do that. It's important to note that the carotidoclinoid ligament that is medial and superior to the posterior bend of the carotid needs to be coagulated and divided. Otherwise, the carotid doesn't let you to move. And the other trick is the inferior paracellular ligament to try to find very early on, because that can give you trouble. Yeah, that is how the best I can answer your question, Dr. Parekh. And the other one is whether I have a holder. And it depends. I do have a holder, and I use the holder very often. Probably there were a couple of videos that the holder was placed. I think that the holder is very useful when you are just with the bone part because it stays there. It doesn't move. There is no shaking. It's relatively safe. And you can move a little bit at your wish. But once you start getting into the cavernous sinus, you need someone that is very skilled in handling the endoscope and understand the distance the same as you. So I think that working with the same rhinologist is key. Big part of the success of this approach is that I'm working with an amazing and excellent, super talented ENT surgeon, Dr. Stavridis, and he's able to provide such a nice access or holding the endoscope. But this is more a two surgeons technique rather than just one man. If that answers to your question.
Thank you. Thank you. Very nice. One more thing, did you encounter any carotid injury during your this approaches anytime?
So yes, I have had one carotid injury, and it was in particular a patient with another cavernous sinus calcified meningioma. I was drilling, and during the mobilization of the carotid, there was a patient that also was radiated, had an injury, but I was able to find the pedicle that, as I said, was coming from the inferior hypophyseal, and with a little bit of coagulation and a little bit of patty, I was able to control. I just wait for 5 minutes. I complete the case. I think I thought it was safe to complete the case. I took the patient for an angiogram, CTA angiogram. There was no significant damage to. It was no damage to the carotid, and the patient was handled well. And I didn't need to do anything extraordinary. But I would say I've done this approaches like from medial wall resection of cavernous sinus to transposition of the carotid is not that often. 40 cases, and that is the injury that I have. It can happen, but even for me, that I'm very junior in my practice, if we follow the landmarks and the way the masters taught us, I think it's completely doable. And I'm just here to prove that um, the skull-based surgery is not just one man anymore. This is a surgery that can be done by anyone in any part of the globe.
Excellent presentation. Very good. And I can understand you have got a great experience and anatomical dissection you must have done to do all these cases so beautifully. Wonderful. Congratulations.
Thank you very much, Dr. Parekh.
Very good, Rafael, and thank you very much for being professional. But we'll have a better turnout the next time. So anyways,
Thank you, John.
yeah, that's about it. So we hope to see you soon, Rafael.
Thank you very much, guys. Really appreciate it, and it's been a deep honor to be here.
Yeah, hold on. I'm just gonna sign off now, okay? Let me just stop recording and get